Okay, so now we're going to talk about quality improvement. Um, all right, our current medical world, issues about quality of healthcare are daily items. We're talking about this all the time, right? Um, Medical profession is in a fishbowl, so is the nursing profession. All right, can you be as safe in the hospital as you are in a jet? Medical mistakes in hospitalized patients account for a minimum of 120 deaths annually. All right, so we've talked about this, right? We want to improve things so that we make people safe, that it's more effective. So I want to talk to you guys about the basic ingredients of quality improvement. So you're using clinical knowledge and experience plus QI concepts and a systems approach. It's pretty basic. You need to take your clinical knowledge and experience and combine it with some basic QI knowledge. Okay, easy. That's what this class is. Then adjust your perspective to a systems perspective, meaning looking at it from a wide approach, not just you, the person, but as a whole. How do we do this? You'll be ready to make a positive system change. So let's look at objectives. Quality problems in healthcare. So the objectives of today's presentation are to characterize quality problems in healthcare in a very broad sense. So we're going to define healthcare quality and to focus on the who of QI. So let's describe the key elements of a good QI project because you'll have some work to do between today's presentation and then when you guys actually do your QI project. We're going to talk about the difference between quality improvement versus research, Joint Commission, and national patient safety goals. Our current medical world, so knowledge and technology is exploding. Barriers to translation of scientific knowledge into clinical practice, increasing complexity of healthcare needs, and outdated processes and systems for complex multidisciplinary healthcare. Think about sacred cows, right? We do things because we've already done them. For many reasons, the scientific knowledge that's available is not always translated to the bedside. This is a complex problem with solutions being studied. And I think that when we discuss this chapter, you're going to understand how to do it. Our patients are far more complex today than they were 20 years ago. Combine that with the fact that very little attention has been given to how we deliver complex healthcare, and now it's time to change that. So cottage industry, individual patient focus, I know it when I see it. So small change has been occurring when we need to accelerate the pace. We've been dinosaurs and now we have to get to an integrated healthcare system. So it's system focused and evidence based. All right, so multiple studies and reports. Our current medical world, with the focus on healthcare deficiencies and the need to improve healthcare quality, has been accelerated by three major factors. In the last decade, multiple studies and reports have pointed out that these are not new facts. This has been known for a while. However, the problem was not acknowledged until multiple studies and reports have been examined in the issues of healthcare delivery and chronic misadventures and errors. So we have widespread and frequent incidents of medical errors and lack of consistency in care. So this is that crossing the chasm, the Institute of Medicine to err is human. I feel like I've talked about it so much to you guys, and I know it gets a little boring and redundant, but it is important to understand the difference between what is scientifically sound and possible and to the actual practice and delivery of health service, and it illustrates the need for healthcare quality and improvement efforts. Quality problems, healthcare services, underuse, overuse, misuse, variation, and fragmentation. Some of the problems with healthcare quality that were identified by the report included these things. In your particular setting, can you think of examples of these? So maybe what is some underuse? We underuse nurses where I work. Overuse. We overuse just giving medication. We misuse the way we communicate with our patients. All right. So the 6 quality aims identified by the Institute of Medicine. Oops, sorry. Safe, effective, patient-centered, timely, efficient, and effective. So safe, avoiding injury to patients. That is intended to help them. Examples, prescription of medication that patient's allergic to, failure to address an abnormal lab or x-ray result, failure to perform a correct procedure. Effective, avoid overuse of ineffective care, obtaining a lab or x-ray that's not going to alter the treatment plan. So somebody says they have low back pain. Getting an x-ray is not going to change the treatment plan. You know you're not going to be able to see anything with an x-ray. So why do you get it? I mean, oftentimes it's because someone bugged you about it. So part of it is just giving that information and educating. All right, patient-centered. Provide care that is respectful of and responsive to individuals. We talked about that. Timely, reduces waits and harmful delays for both those who receive care and those who care. Efficient, avoid waste, including waste of supplies, equipment, ideas, and energy. Equitable, provides care that does not vary in quality due to gender. All right, so defining quality. Quality is a way of thinking about work. Quality is not about achieving excellence, nothing less. So the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. It's a system-wide issue. Simply stated, quality is an attribute of a system. It requires teamwork among healthcare providers to achieve. I'd like to state that again, quality is a system issue that requires a team effort and commitment. However, we will see that individual accountability is a key component for a well-functioning system. Quality improvement is a process of innovation and adaptation designed to bring about immediate positive changes in the delivery of healthcare in particular settings. It's systematic, data-guided, and multidisciplinary. So what is the difference between QI versus informal improvement? So QI is systematic. You use data to guide and inform you. Experiential, innovative, employs formal, explicit methodology. It's continuous, core responsibility, and it uses the system to change. It's team-oriented, requires team skills, and you develop local new useful knowledge to inform healthcare processes.
Hi, in this video we're going to talk about PDSA cycles, which are a simple yet powerful tool for quality improvement in healthcare. Systems in healthcare environments are complex and never stop. Changes to these systems need to be thought through and carefully implemented and tested. PDSA cycles lead to a process of change that is structured and reflective, rather than impulsive and chaotic. The cycle has 4 stages: plan, do, study, and act. The plan stage has 3 parts. The first is finding the issue for improvement. All issues are different, so there are many ways of doing this. Maybe interpreting data, or staff and patient feedback. Issues pop up in unexpected places, so you've got to be on the ball to notice them. The second part is coming up with a change that could make things better. Maybe something like improving staff teamwork or communication. Also, there may be a few different changes that could work. Decide on the one you think will work best, and give it a go. The third part is predicting what will happen when you make the change. Predict some of the impacts it will have and write these down to review later. The do stage is putting the change to the test, carefully. First, you need to prepare for your test. For example, giving the staff training they'll need, or making sure all necessary resources are in place. Once everything's in place, test the task out on a small scale. Try it out on a patient or a small group of patients first. Then, if it doesn't work, it will be easier to remove. It's also less risky. While you're doing the test, keep track of it in real time through a continuous monitoring system. The study stage is a reflection on the results of your test. Look at the results you collected from your monitoring system. What has changed? Who have these changes affected? And how? Have the effects been positive or negative? Are the changes worth keeping or even developing? How do these effects differ from what you predicted would happen? The act stage is responding to your reflection. You need to decide whether to spread, stop, or improve the changes. If it was successful, maybe carefully spread it to more patients, little by little. Perhaps it was beneficial, but there are areas that need some work. Maybe it had negative results and needs to be removed. In healthcare, quality improvement is an ongoing process. This means that PDSA cycles don't end, but become linked to another cycle, incorporating what was learned from the previous cycle. Using the PDSA cycle, sustainable, continuous improvement can be achieved leading to satisfied staff and happy patients.